Screening has been shown to have significant benefits. It reduces metastatic prostate cancer and prostate cancer deaths, but it wasn't always done perfectly in the past. Patient selection is really important in focusing screening efforts on men with a long life expectancy. Our screening strategies have also been evolving over time. Early on, a lot of the studies just used total PSA and used one threshold to decide on biopsy for everybody. Now we recognize that it's really more of a continuum. PSA reflects the spectrum of prostate cancer risk. So somebody with a 3 has a higher risk than a 2, and a 4 is more than a 3. So really it's more of a continuous indicator. And there's many other factors that are important to consider in decisions. So the patient's risk factors like family history, previous biopsy history, all of that should be taken into account. So nowadays we can give patients a much more personalized estimate of their risk of having a high-grade cancer on biopsy. The other big advance is the availability of new markers that are more specific than just the regular PSA test. There's 2 new tests in particular, the Prostate Health Index and the 4K score, that are kind of like new and improved versions of PSA, where they are just a blood test and they're really based off of PSA, but they're more specific for clinically significant disease. So the goal is really to still have early detection, because prostate cancer is the second leading cause of cancer death. So we do need to find those life-threatening cases early in order to cure them. However, what we don't want is overdiagnosis of indolent disease. So using better screening strategies to try to focus on the detection of clinically significant cancer is important to maximize the benefits and reduce the harm.